gentlemen and colleagues. Thank you for joining the open online course on nutrition status assessment and macronutrients roles in patient management. First of all, I would like to thank the Clinical Nutrition Department, Physician Nutrition Specialist Study Program for arranging this webinar. It's been an honor for me to be a moderator for this event. Let me introduce myself. My name is Dr. Grisadel Vastanto, Physician Nutrition Specialist. We are pleased to inform you that among us here, we have two experts as speakers, Dr. Vyastuti Wijaksono, Physician Nutrition Specialist, and Dr. Nurul Ratnamutumanikam, Physician Nutrition Specialist. Good afternoon, Dr. Vyastuti and Dr. Nurul. To all participants, thank you.
Good afternoon, Delva.
Good afternoon, Dr. Vyastuti. To all participants, thank you for taking your time to attend this webinar. First, I invite Dr. Vyastuti to present a brief explanation concerning nutrition status assessment. Dr. Vyastuti, time is yours.
Okay, just wait a minute. Okay, this is my presentation about penentuan status gizi untuk tata laksana pasien. So we will describe what kind of penentuan status gizi. I think the important thing is how to cara penilaian status gizi. The meaning of cara penilaian status gizi is how we describe the nutritional stages. It's from the asupan or intake, and then the body weight, and then the anthropometry, the objective data from anthropometry, clinics, and laboratory, and another supporting examination. If we discuss about the intake, this is the important thing. And then if we discuss about anthropometry, body weight, and then height, and then the BMI is very important one. And the other is, the important thing is the other examination for support the nutritional status. This one is the important one for the fat-free mass, and then fat mass, and the water accumulation in our body.
And then, sorry, you may slide show for your screen.
Oh yeah, sorry. Okay, just wait a minute. Yeah, and this is for clinical examination for fat, and then this is the clinical nutrition for fat-free mass and muscle or fat-free mass, and this is for the all the water in our body, and this is our laboratory examination. The important thing is hemoglobin, albumin, and C-reactive protein, and the other is other support, like we examine the dynamometer Jamar, yeah, for kekuatan genggam, and then maybe we can use the BIA, body impedance analyzer, and to measure another body composition with the clinical. This is the dynamometer, and this is the body impedance analyzer, and this is the important of malnutrition screening tools. We usually use the very easy one, yeah. This is we use in our hospital, the MST, malnutrition screening tool, and this is the body weight and the waist circumference. Yeah, this is the BMI, cut off the BMI for normal and for underweight and for overweight, and this is for waist circumference, risk of comorbiditas, and this is the WHO criteria for malnutrition. And then we have another malnutrition criteria from ASPEN 2015, and then from ASPEN 2012. And this is the malnutrition grade. We can use the from the intake, and then the weight loss, and then the BIA for the fat-free mass, and then water, and then the hand grip of the patient. I think that's all my presentation. Thank you very much for your attention.
Thank you, Dr. Fias. And now I would like to invite Dr. Nurul to deliver a concise explication about macronutrients roles in patient management. Dr. Nurul, time is yours.
Okay, thank you, Dr. Delva. And good afternoon, all the participants. Thank you for joining this module. And also, thank you very much. You have read all the material from us. And now I would like to present just a little about the macronutrients. This is a technical issue. Sometimes it's getting error. Yeah, this is macronutrients. And if you remember about macronutrients, there are carbohydrates, including fiber, and also protein and fat. In carbohydrate, we have two main kinds of carbohydrates. It is complex carbohydrates and also simple carbohydrates. And we know that from simple carbohydrates, only the monomer units only contain 1 until 2, and oligosaccharides considered as 3 until 9 monomer units, and complex carbohydrates have a polysaccharides with more than 9 monomer units. And the example of sugar is are glucose, galactose, fructose, sucrose, maltose, lactose, sorbitol, and mannitol. And we consider these kinds of components are a simple carbohydrates, and we know that it will absorb well and very fast, and it will increase the blood glucose than polysaccharides. And the benefits of carbohydrates, it contains in 1 gram of carbohydrates contain 4 kilocalories with protein sparing effect, and also this is the main source of energy for our body, especially for nerve cells and red blood cells. And fiber, it is also important because fiber can inhibit the absorption of cholesterol and also carbohydrates, so it will prevent the increase of blood glucose as well as fiber, as well as cholesterol levels in our body. The classification of fiber, there are soluble fiber, insoluble fiber, and fiber-like substance. And fiber-like substance is very unique because it acts as prebiotic or bifidogenic effect, and it can protect intestinal barrier, thus preventing GI tract infection. This is the example of soluble fiber, and it is insoluble fiber. And protein also essential for our body. There are 2 kinds, essential and non-essential. Essential amino acids means that the body Our body cannot synthesize itself, but in non-essential, the body can synthesize itself. And we recommend to consume high biological value of protein because it contains almost all the essential amino acids good for supporting body growth and as well as generally found in animal source. Then in low biological value, it's generally found in plant origin or plant protein. And the amino acid contents are incomplete in low biological value of protein. And the last is about fat. There are triglycerides, cholesterol, and phospholipids. And cholesterol, remember, only found in animal source. So the fat origin from plant does not contain cholesterol. Fat also has an essential because the body cannot synthesize itself. And this essential fat is considered as omega-3 and omega-6 fatty acid. And essential fatty acid can produce eicosanoid that can regulate our inflammatory effect in our body. And this is the eicosanoid taken from omega-6 and omega-3 fatty acids, and it will regulate our inflammation in our body. This is the role of fat, function as energy reserve, and also solvent fats soluble vitamins and promote satiety and slowing gastric emptying. And remember, in 1 gram of fat, it contains 9 kilocalories. And this is the food source. Omega-3 fatty acids, which contains EPA and DHA, only found in fatty fish. So this is in marine products. But other omega-3 also can found from plant origin, but does not contain EPA and DHA. And omega-6 fatty acids usually contain saturated fat. And remember about cholesterol, it is only in animal source. For example, organ meat, lobster, and also egg yolk. And from our daily needs, to prevent increasing of lipid profile, only less than 30% from total needs, which contains saturated fats less than 7%, and PUFA up to 10%, MUFA up to 20%. Okay, this is all from me. Thank you very much for your kind of attention.
Thank you, Dr. Ivastuti, for your presentation. And now we are arriving at the time for question and answer. Because of most participants is from Indonesia, it's okay for Dr. Ivastuti and Dr. Nurul if you want to answer in Bahasa. The first question is for Dr. Ivastuti. In obesity and body weight classification, there are body weight criteria such as average, moderate, and increase. Are there any cutoff for that criteria?
Okay, this is about the overweight and obesity classification and the risk of comorbidities ya. Pertanyaannya tentang risiko dari comorbidities dari obesitas ya, Delva.
Ya dok, apakah ada cut-off-nya untuk kategori rata-rata, sedang ataupun meningkat dok?
Di sini sebetulnya cut-off-nya yang kita pakai itu adalah BMI atau indeks massa tubuh ya. Jadi dengan indeks massa tubuh indeks massa tubuh dan lingkar pinggang atau waist circumference. Artinya dengan indeks massa tubuh tertentu dan lingkar pinggang tertentu itu akan akan menggambarkan bahwa risiko dari comorbidities itu bisa rata-rata sama dengan orang normal atau bisa meningkat. Memang kita tidak punya cut off khusus meningkatnya berapa persen, itu tidak ada. Tetapi kita menggunakan meningkat secara moderate atau meningkat secara severe atau very severe. Tapi cut off yang dipakai hanya cut off untuk BMI dan cut off untuk lingkar pinggang. Demikian jawaban saya, Delva.
Okay, thank you, Dr. Piastuti. And now, question for Dr. Nurul. Dr. Nurul said that to control glucose and fructose intake, such as from honey, doesn't honey contain an anti-inflammatory and have lower glycemic index than sugar? Can honey be alternative for diabetic patient to reduce sugar consumption?
Yes, we know that honey doesn't contain anti-inflammatory properties, because anti-inflammatory properties only contain in eicosanoid, because it will regulate our inflammatory process in our body, not by honey. And the glycemic index in honey is higher. So it is almost the same with simple sugar. So almost 100, the glycemic index. And honey is really poor of fiber. So very little of fiber, and it cannot be an alternative for diabetic patients. So remember about this. If there is a wound, we can apply honey as medicine, but not for consuming, because the glycemic index is higher. So it is recommended for diabetes to consume a low calorie sugar sweetener coming from aspartame or azosulfam K or from sucralose, because it is safe, and based on the USDA, it is also safe for diabetic patients, and it can be used for long term, so not from honey. Thank you, Dr. Delva.
Thank you, Dr. Nurul. And now question for Dr. Piastuti again. Are there any alternative of body height measurement for humped elderly or patient with spinal disorder? Also, how to measure body height in body mass index in patient with amputated extremity?
Okay, thank you, Dr. Delva. I think we are in English. So same with Dr. Nurul. Yeah, I think for the height measurement, we can use knee height measurement for somebody who can stand up, and then we can use pengukuran rentang lengan, or in English maybe we said it arm span measurement. Yeah, so we can still measure the height of the patient with other method, not only measure the height of the patient. I think that's my answer. Thank you.
Okay, thank you, Dr. Piastuti. And now a question for Dr. Nurul. Naturally, fruits contain glucose and fructose, but it also contains soluble fiber that can inhibit sugar absorption. What is the general recommendation for diabetic patient in consuming fruits?
Well, okay, thank you. We know that in fruits contain fiber, but as well as it also contain fructose or gula buah. Yeah, so for diabetic, still consume fruits, but we have to choose the fruits with low sugar or low glycemic index, or less fructose in fruit. For example, papaya, apple, strawberry, kiwi, avocado. It is kind of fruits that low fructose intake or low fructose contain inside. But remember to avoid consume like banana or watermelon, or for example watermelon, banana, and also orange, because it is sweet. So not all fruits is safe for diabetics. So we have to check again about the fructose contains in fruits for diabetics.
Okay, thank you, Dr. Nurul. And now a question for Dr. Fias. How to determine nutritional status in patients with kidney disease, acute heart failure, and hepatic cirrhosis, especially measuring muscle mass, fat mass, and fluid retention. How to calculate body weight in edematous patient.
Thank you, Dr. Delva, for the question. I think we can measure the muscle mass or fat mass by clinic, I think as a clinician, we can look at the temple region, and then we can look at the clavicula of the bone region, and then maybe scapular bone and dorsal head. That's show us how is the muscle of the patient. Or maybe we can use the patellar, and then the musculus quadriceps and musculus gastrocnemius. That's for the muscle. And then for the fat, we can use the orbital region, and then orbital fat pad, and then upper arm region, and then thoracic and lumbar region. That's for clinical measurement. But we can use two body impedance analyzer. That's more objective. Yeah. The clinical measurement is more subjective, but the more objective one, we can use body impedance analyzer. For the EDEM people, we can calculate the body weight by reducing maybe 5 to 10% for the edematous condition. That's my answer. Thank you.
Okay, thank you, Dr. Fiastuti. For Dr. Nurul, what is the balance ratio between omega-3 and 6?
Yes, the balance ratio omega-3 and omega-6, the recommendation is 1:3 until 6. So for example, 1 unit of omega-3 or 1 gram of omega-3 fatty acids. The ratio to omega-6 is about 3 until 6. So omega-6 is more than omega-3. But not in naturally compound, for example, from marine product, the ratio between omega-3 and omega-6 is 1 to 9 until 10. So the omega-6 fatty acid is more than omega-3. It is functional and it is normal, because our body just require omega-3 fatty acid in a little amounts, not as high as omega-6. So it is recommend to have 1 to 3 until 6. Omega-3 is 1, and omega-6 is 3 until 6. It is the balance ratio to regulate our eicosanoid in our body.
Okay, thank you. And next question is, How many sites does it need to determine fat loss and muscle mass loss in diagnosing malnutrition? The question is for Dr. Fiastuti.
For the mild and moderate, yeah, Delva.
Sorry, Dr. Fias.
What is the question? Sorry.
How many sites does it need?
Oh, yeah. Okay. I think as per criteria for the subcutaneous fat loss, we need some site, yeah, like orbital region, and then orbital, and then upper arm region, and then overlying tricep, and then thoracic and lumbar region, and mid axillary line, ribs, iliac crest, and lower back. Yeah, so I think we have 5 sites to determine the loss of subcutaneous fat. And then for muscle, we have a lot, yeah, site for assessing the muscle loss, like the temple region, and then the clavicula bone region. Like my slide, I already give to the participant. I think that's should be measure all the site to determine if somebody have a muscle loss or fat loss. That's Delva.
Okay, thank you, Dr. Fiastuti. And now, question for Dr. Nurul. Can we suggest diabetic patient with low glycemic index food? If it is suggested, how much is the recommendation for consuming low glycemic food?
Yes, we have to choose low glycemic food for diabetes. Let me show you a presentation, little presentations about glycemic index. It is visible. Is it visible for participant?
Yes, Dr. Nurul.
Yes. We have to know about the factors that influence the glycemic response to food, like rate of ingestions. For example, raw apples versus apple juice. So in the raw apple has a low glycemic index than apple juice, because in raw apples, it is still contain of fiber than apple juice. And also food components. For example, fat, protein, and fiber contain. In one meal, if there are fat, proteins, and fibers, so the glycemic index and also the glycemic response will be lower than only carbohydrates, because we know that higher carbohydrates has a higher glycemic index. And also food form, for example, bread versus pasta. In bread, especially white bread, contains very high glycemic index and also has glycemic response than pasta, because we know that pasta also contains fiber, and also it contains other components, not only carbohydrates. And methods of cooking and processing foods also influence the glycemic response and glycemic index in our meal. And also physiological effects like gastric emptying, intestinal hydrolysis, and also absorption. And this is the example of higher glycemic index, intermediate, and lower. How much? The question is how much? Because our body needs carbohydrates, which is from breads or white rice or potatoes, pancakes, or from some cereals. So it is impossible for us to avoid this food, because this is our staple food and our needs for in our daily needs. So how many carbohydrates contains that we need for regular diet? Still, for diabetes, need 50%, 50 until 60% of carbohydrates from total needs, from total daily needs. But you can choose intermediate intermediate glycemic index than higher glycemic index. But if you consume, for example, white rice, so not only white rice that you have to consume, you have to mix with fiber and also protein and fat to reduce the glycemic index contained in your meal. So in diabetes, can still can consume higher glycemic index, but in mixed dish, not only one from white rice only, no, or from potatoes only, but have to mix with other dishes. That's all for me. Thank you, Delpha.
Thank you, Dr. Nurul. The next question is about how to differentiate mild, moderate, and severe depletion in muscle mass and fat mass according to Aspen criteria. These questions for Dr. Fiastuti.
Okay. I ask a permission to share screen so easier for everybody to see. Sorry. This one, yeah. Okay. Sorry, my presentation is wrong PPT in Indonesia, but this is in English. This is, we can see the how to assess the subcutaneous fat loss, the normal, mild, and severe loss. Yeah, it's easier for us to see. Say it, we can see the orbital region. This is the techniques show us. We stand directly in front of the patient and view, and then we can touch below the eyes or above the cheekbone. And then after that, we can determine, is it normal or mild or severe? The normal one, we can touch the slightly bulged fat pads, and then the mild to moderate loss of fat loss, we can look at the slightly dark circle, and then the severe loss, we can see the hollow look, and then depression and dark side circle and loss of skin. Yeah, this is the PowerPoint in English, so easier maybe to understand. And then this is, yeah, for every site of specific area, we have a specific determination of how the condition. So we can decide, is it normal, mild, or severe loss? Yeah, we need some keterampilan to assess it. This is the fat loss, and then just a minute. This is for muscle loss. Yeah, there's some area, and then how to determine, is it well nourished, mild, or severe malnutrition? And yeah, this is another muscle loss. Yeah, I think this the way how to differentiate with the mild and moderate malnutrition, severe malnutrition compared to well nourished. I think that's my answer, Delva. Thank you.
Okay, thank you, Dr. Fiastuti. And now a question for Dr. Nurul. What is the example of fiber-like substance?
Let me share screen again. Okay, this is the example of fiber-like substance. The fiber-like substance contains of inulin, fructooligosaccharides, and chitosan. The monomer unit is about 6 until 9 of monomer units. and it also considered as oligosaccharide. And inulin, fructose or fructooligosaccharides or FOS and chitosan has a prebiotics properties because it will stimulate or increase the good bacteria in colon, especially bifidobacteria and others and other kinds of probiotics. And the food source of fiber-like substance can be found in chicory root, onion, garlic, leek, and banana. And we know chitosan, it is an animal-derived materials that resist digestion, and the food source is, for example, is from crustacea, from shrimp, crab, and lobster. Why it is considered as a fiber-like substance? Because it has a property contain mix from soluble and also insoluble, because it is soluble fiber, but the property itself can this is can increase the bulk of feces, and also the prebiotics properties very unique in fiber-like substance. So this is the benefit and also the example of fiber-like substance.
Okay, thank you, Dr. Nurul. Now the question is about how to measure reduced functional status using hand grip if we don't have the initial hand grip value.
Yeah, I think the important thing to know the decreasing the hand grip is we use the initial one, because if we need some cutoff, I think, for the hand grip value, and we can use this if we don't have the initial hand grip value, I think.
Okay, thank you, Dr. Fiastuti. And now, question for Dr. Nurul. What is the benefit of monounsaturated fatty acid than polyunsaturated fatty acid, since it is recommended to consume more MUFA than PUFA? What are the food sources of MUFA?
Okay. Okay, let me share the screen again about MUFA. Yes, this is MUFA, or monounsaturated fatty acid. We know that from diabetes care, from publication from diabetes care, it can it will regulate the fasting and postprandial plasma glucose concentration, and also can reduce the A1C levels. This is the RCT to compare between both high protein, high MUFA, and low protein, high MUFA. So the complex meal that contains of high MUFA, it will regulate or alter the fasting and postprandial plasma glucose and A1C. And from systematic review and meta-analysis from diabetes care also, diabetes-specific formulas containing high MUFA significantly produce better glycemic response compared with standard formula. Because our body needs more MUFA than PUFA, so the recommendation of MUFA is higher than recommendation of PUFA. So we know that the recommendation of MUFA is below 20%, but PUFA only 10%, because our body normally needs MUFA more than PUFA. And high MUFA diets have not been shown to improve fasting plasma glucose or A1C level, but it is taken from other publication from ADA. But still, we can use MUFA more than PUFA in diabetes, because based on recommendation is more MUFA than PUFA. The food source of MUFA are from canola, olive oil, canola oil, and also avocado. So we can add this oil or avocado in our daily diets to gain MUFA and to meet our MUFA needs from daily diets. Thank you.
Thank you, Dr. Nurul. And now, question for Dr. Fiastuti. Are there any contraindication for BIA examination? When BIA is unavailable, are there any alternative examination?
Sorry, Elva, your voice is gone.
Okay. Are there any contraindication for BIA examination? When BIA is unavailable, are there any alternative examination?
Okay, there's the contraindication for BIA is relatively contraindication. Like because the BIA use is to compare with the normal normal condition and then depend on age. So if we measure the child or adolescent, sometimes it's not show us the real body composition. And then for some people who are very obese, sometimes the body composition can measure very the best measurement. And then maybe for some people with ODIM, maybe the data, because we use the comparable of the normal and the age. So that's the important thing. So I think we have to know. And then what kind of measurement we can use if we don't have any body impedance analyzer. We can use with the we call it what is it? Skin fold thickness. Skin fold thickness, and the skin fold thickness we can use caliper, yeah, in some area like in the bicep and then tricep, and then subscapula, and then suprailiaca, and then mid of the mid in the mid of what is it? Just wait. There's some area we can use, or maybe we can use the CT scan, and then the DEXA and the MRI to measure the body composition. Yeah, that's my answer.
Okay, thank you, Dr. Fiastuti. And now, question for Dr. Nurul. If we are about to consume a lot of monounsaturated fatty acid and polyunsaturated fatty acid, will subcutaneous fat be formed?
Okay, if we consume only 25 until 30% of fat from our daily needs, and also with less of trans fat and saturated fat, it cannot increase our subcutaneous fat. So means that if we consume fat with based on recommendation amount, it will not increase our subcutaneous fat. But remember to increase our energy expenditure to prevent and also to reduce our subcutaneous fat in the body. So don't be worried to consume MUFA and PUFA, and also less of saturated fat from our daily diets. And also remember to increase physical activity by exercise to prevent and also to avoid subcutaneous fat as well as visceral fat. And it cannot MUFA and PUFA because it is unsaturated. So it will improve your lipid profile in laboratory. So don't worry to consume these kinds of fat. Thank you.
Okay. Next question for Dr. Viastuti. How to determine energy intake in hospitalized patients? Is using 24-hour recall, or there are any another methods, especially for long-term food intake, such as within 1 month?
Okay, we have two methods, the qualitative and the quantitative. Yeah, the quantitative, we can use the food recall or food record. I think the best way to measure our intake is with weighing the food. That's the best way. But I think it's not easy to do that method. If the quantitative, like the intake, the recall, the best way is use not only 1 day. We can use more than 1 day. But the qualitative, especially for the long term, maybe we can use the qualitative like food frequency. The food frequency is usually a qualitative measurement, but it become almost quantitative if we do have, or we do ask the portion and the frequency of the patient usually eat. I think that's my answer.
Okay. And now question for Dr. Question for Dr. Nurul. It is mentioned that soluble fiber can delay sugar absorption. How does it affect protein, vitamin, or drug absorption?
Yes. Let me share my screen again. Is it visible?
Yes, Dr. Nurul.
Yes, we know that soluble fiber can make a gel formation in our stomach and also delay gastric emptying. So it will flatten our blood glucose curve and also reduce the insulin surge. So that's why it will interfere the absorption of carbohydrate, especially simple carbohydrate. Insoluble fiber also delay gastric emptying, interference with digestive enzymes, interference with micelle formation, and also inhibition of cholesterol biosynthesis. And we know that from gastric emptying, it will flatten glucose curve, and in digestive enzymes, it will impair absorption of lipid and carbohydrates. So it will reduce the cholesterol available for cholesterol synthesis. And for micelle formation, it may binds bile acids and reduce bile absorption. So the cholesterol will be decreased too. And also inhibition of cholesterol biosynthesis, so it will reduce the cholesterol biosynthesis. So it will lower serum cholesterol as well as glucose or glucose level in our blood. But in other than protein, vitamin, and drug absorption, soluble fiber, because it also contains phytate and also fiber, it will also interfere the absorption of protein, vitamins, and also drugs. So it is better for you if you consume soluble fiber has a duration with protein, vitamins, or other supplementation or drugs. So the duration is about 1 until 2 hours before or after consume drugs or supplementation, because it also interfere or have inhibition of absorption. So the amount of protein, vitamins, minerals, and also drugs will be reduced if you consume with the limit time or duration time is very short. Okay, this is my explanation.
Okay, thank you, Dr. Nurul. And now question for Dr. Fiastuti. In Aspen malnutrition criteria, hand grip strength are written not applicable or NA for moderate malnutrition in chronic illness. Can you please explain furthermore about this case?
Yeah, I think because the malnutrition criteria, especially the severe malnutrition, usually show us the severe one that the hand grip strength will decrease, but it is not in the moderate malnutrition or mild malnutrition. So yeah, that's the important thing for us to diagnose our patient with the severe malnutrition if there's a hand grip strength decreasing. Yeah, that's my answer.
Okay, thank you, Dr. Fiastuti. And now, question for Dr. Nurul. How can a vegan diet meet their need for fat and protein, especially the types of fat and protein that mostly come from animals?
Yes, in a vegan diet, usually also consume special meal for vegan that also fortified by vitamin B12 and also calcium and iron. So it will prevent from vegan population to prevent deficiency, especially vitamin B12, because we know that vitamin B12 only found in animal protein or animal origin. So it is recommendation for vegan to consume special diet for vegans that has fortified by minerals and also vitamins, especially vitamin B12.
Okay, due to our limited time, this will be the last questions for each speaker. The last questions for Dr. Fiastuti. There are cases where either family or patients are unable to describe weight loss and food intake, such as in ICU or stroke unit. The only data we can find is based on emergency room screening and without detailed information. How to assess patients with this condition?
Yeah, if we want to diagnose the malnutrition, we have some criteria. We can use the WHO criteria, and then we can use the Aspen criteria, and then we can use the Aspen, and the new one is the GLIM criteria. The important thing is only what is the disease, and then is there any weight loss? Without describe weight, we can ask the family, is there any weight loss or is there any intake, decrease intake? Yeah, I think the important thing like that too. I think our screening to use, is there any weight loss or is there any decreasing of intake of the patient? Yeah, that's the important and the easiest way to make risk of to determine the risk of malnutrition. I think that's my answer, Dr. Delva.
Okay, thank you, Dr. Fiastuti. And the last questions for Dr. Nurul. Can you explain, Dr. Nurul, about protein sparing effect?
Yes, protein sparing effect means our body prevent the proteolysis because of lack of carbohydrate. We know that carbohydrate is the main source of energy. So if the body needs, if the body cannot meet the appropriate amount of carbohydrates, means our body needs energy, glucose from protein. So that's why our protein storage will be lysis, or it called proteolysis, to produce energy or to synthesize carbohydrate from protein. So means that protein sparing effect means that if the carbohydrates cannot be met from our body, so we metabolize storage of proteins. How about fat? We know that fat also contains energy, and it is energy reserves for our body, but it needs longer time to lysis than protein. That's why our body quicker to lysis the protein stores than fat stores. This is my explanation. Thank you, Dr. Delva.
Okay, thank you. And we are come to the end of this webinar. Before closing the webinar, let me draw some conclusion. Assessment of nutritional status can be performed through some method. The easiest method is through calculating the body mass index. Nevertheless, a more accurate assessment is required for identification of malnutrition in the hospital context. In this perspective, it is carried out through determining the risk of malnutrition using the ASPEN and ASPEN criteria. Each macronutrient component has a specific role. Carbohydrate is needed as the main source of energy that does it prevent protein sparing. Fiber, a part of complex carbohydrate, is needed to help the digestive process. Protein has roles as a building block, and it also regulates various kinds of body metabolism. A good type of protein is one that has a biological value. And for fat, fat has roles in helping the absorption for fat-soluble vitamin, increasing food palatability, and reducing inflammation through fulfilling the requirement of essential fatty acid. That's all, everybody. Thank you, Dr. Fiastuti and Dr. Nurul, for your informative and interesting presentation, and for all participants for your very active participation. I would like to apologize if there are many mistakes of me as a moderator for this session. We hope you all learn the essentials today. Well, I am Crisadel Pastanto. Have a great afternoon. It was nice to see you again.
Thank you.
Thank you all. Thank you for your presentation and also participation. Have a nice day.
Thank you. Stay healthy. Have a nice day.
Dr. Fiastuti and Dr. Nurul, may we take a photo? Kita foto ya.